Okay, first of all, let me thank you for invitation. I'm more than happy to do my presentation. Like we said, it's multidisciplinary approach to enhance the ability of neuromuscular dentistry. And I don't know how many of the audience familiar with this concept of neuromuscular dentistry, but let me just tell what does the neuromuscular concept means in dentistry. For those of you who are not familiar with this concept at all, I will explain that when we're talking about neuromuscular dentistry, we mean that it is based on the three main components. The first of all, this is a physiological approach. Physiological approach and multidisciplinary approach. And also objective data diagnostic procedures. In the physiological approach, first of all, we take into consideration the muscles of the head and neck. And if the muscles need to adapt to wrong, meaning not physiological position of the lower jaw, or some prematurities, then they will respond with a hyperactivity, spasm, or chronic fatigue, and basically in real time. And we can objectively we can objectively measure the condition of the muscles with the help of a superficial electromyography. We can measure the amplitude and frequency of the muscles during the rest and during the function, which gives us an idea of the state of the entire craniocervical dental system. Why? Because the muscles react by changing the tonicity to the incorrect position of the lower jaw or presence of the supercontact, so presence the nerving of the airway. It's like instant. That's why we can use this data in our diagnostic procedure. Therefore, we're using EMG values in conjunction with the kinesiography to record therapeutic occlusion in the treatment of patients with TMD, with sleep apnea, or aesthetic rehabilitation of dentitions. Not methods based only on anatomical structures, such as a position of the head of the joint, but we based our diagnostic procedure on a physiological indicators. All right, another physiological indicator is the condition of the respiratory tract and respiration. In addition to measuring the size and value of the airway, we notice what if the patient has a tonsils or adenoids, or his mouth breather or not. We also conducting the sleep study to determine if the patient have an upper airway resistance syndrome or it has obstructive sleep apnea. According to the studies, 75% of the patients with the temporomandibular joint disorder have symptoms of obstructive sleep apnea, and vice versa. 80 to 90% of the patients with sleep apnea have symptoms of TMD. Therefore, in our clinic, until we have conducted a sleep study and prove opposite, we believe that the patient has a sleep apnea. Again, we diagnose the patient and treat the patient like he has a sleep apnea, since like 90% of like crossover here, until we prove that he doesn't have a sleep apnea or upper airway resistance syndrome. And this actually helps us to bring our success level to the 87%. So 87, the patient asked me, so I'm going to do treatment, I'm going to pay a lot of money, how successful it's going to be? And I know the answer because we conducted this study in our institute. It's 87%, 87%. And this percent become much higher. Before it was like around 60, much higher when we consider this sleep apnea issue with the patients. All right. The second thing, actually the third physiological component, is a nervous system. Nervous system. If the movement of the jaw is controlled by muscles, right? Then the muscles are controlled by central nervous system. The frequency of brain activity is associated with various stages and activities of the body. For example, relaxation is associated with the alpha frequency of the brain, which is 8 to 12 hertz. But if despite all efforts, what we can use to relax the patients, the central nervous system continues to work with a high frequency, like beta frequency or high beta frequency, right? Then it will be very difficult to achieve the relaxation stage of the muscles. So that's why we doing electroencephalography. We can determine the frequency of CNS waves using electroencephalography. However, in a dental office, in the real like clinical situations, very difficult and expensive to do classical electroencephalography. But we use a fairly simple device that allows us to determine in real time at what frequency the brain works. And this company called Brain developed this. It's not very accurate. You can use this to do like diagnosis of sleep apnea, for example. But for our purpose, to determine in a clinical setting what the electroencephalography looks like for the patient, it's very good, very simple device. And you can see how it works in a real clinical setting. The examination itself is carried out within a few minutes and give us a fairly accurate result of electroencephalography. The sensors are located in this tape, what you see on the patient head. And we put this tape a certain way and record the signal using Bluetooth, and you can record this signal with computer or with your iPhone or any like smartphone. Please don't think that we need to shave patient head, okay? The sensors receive the signal through the hair, all right? And if we ask the patient to relax, we turn down the lights, we put the nice music, we put some warm towel around the patient's neck, and then normally we see the predominance of the alpha frequency. You see, like in this example, you see this blue area, it's 81.7%. We would like to see at least 65% predominance of the alpha frequency in normal situation. It telling us that central nervous system has a high vitality and adaptive adaptation, like opioid system adapt very well for this patient. But on the opposite side, if the beta frequency predominates, then this indicates depletion of CNS vitality and its adaptive forces. It is unlikely that in such state of the central nervous system, we will able to relax muscles. You see, it's alpha, it's only like 17.6%, and beta is 70. And if you do everything to relax patient and it doesn't work, then it's straight indication to use NewCam, for example, which allows us to naturally relax the brain and body within the minutes, and which is very important, without any drugs. It consists of 4 elements: eye mask, noise canceling headphones, NewCam biosignal processing discs, and NewCam neuroacoustic software. But the main element is a neuroacoustic program. This software with a frequency following response technology that uses binaural beats to entrain the brain to alpha theta states, which is like first stages of sleep, characterized by brain wave frequency between 4 and 12 hertz. And you can see again how we use this system. As you see, we put the NewCam, and just notice in the beginning the alpha frequency is very low, this kind of blue area. And in a few seconds, basically, you see how like it's raised. It's raised. It's like 71% here, more than 70% here. And you can see it's in the real time. This is what's happening. This is what's happening. Again, this is the same patient. You see how stable the alpha frequency. Usually, in the 10-15 minutes, patient ready to take a bite. And as you know, maybe some of you know that we need to tense patient for like 45-60 minutes. But with NewCam, with this technology, you can cut down the time to the 10-15 seconds. And I can prove it to you later. But as a result, the patient enters the parasympathetic stage. People feel relaxed and rested. They fully cooperative. They calm and still, and they also indifferent to time and environment. It's a very, very good system. We using this new calm system not only to relax patients before establish the neuromuscular occlusion. We use this technology all the time because this is what we want to see. For any dental work, we want to see fully cooperative patients with the patient calm and still and different to the time and environment. So this is very good. And this is a muscle electromyography before and after muscle relaxation using TENS, transcutaneous electroneuric stimulation, and this system what I just explained you. And this was done for 10 minutes. This procedure was done 10 minutes. It's like 10 minutes between electromyography on the left side and electromyography on the right side of the screen. And you can see how low and how balanced the electromyography of the temporalis muscles. You see, this is like temporalis muscles on the first two lines, the black and red. When used in combination, like ALF-TENS and NewCam, the result allows for deep muscle relaxation, and also it decreases the time of the TENS. And also, we conducted study in our institute. We conducted study. We took this 28 patients, and we did a NewCam, and we did a electromyography. And then we took encephalography, and we found that when we checked the distribution of the patients with beta and alpha after NewCam, we saw that 25 patients had a predominance of alpha frequency of temporalis. It was less than 2.5 microvolts, which is a huge, but it's like 89%. But 88% of them had an AMG less than 2 microvolts. And the conclusion of this study was based on the data obtained. It can be concluded that there's a direct correlation between the predominance of the alpha frequency of the brain and low EMG values of the temporalis. The use of the neuroacoustic software with a frequency following response technology made it possible to effectively activate the parasympathetic response of the central nervous system and stimulate the brain to have an alpha frequency in 89% of the subjects. So this is a conclusion of this study what we kind of conducted several years ago. All right. Now, we also talked about multidisciplinary approach. On this diagram, you can see that occlusal problems, TMJ problems, it's multifactorial thing. It's like cranial bones. It's a condition of the cervical spine. It's position of the and development of the upper and lower jaw. This is a microocclusion, how the teeth comes together. This is general health. This is muscle joint. So it's many things. It's very complicated medical, not dental, medical issue. That's why we need so many specialists to treat our patients. First, our helper is a chiropractor or osteopath or physical therapist, ENT doctor, psychologist, psychiatrist, neurologist, cardiologist, all of them. We can't treat TMD patients alone. It's not just produce some night guard, what, I don't know, many dentists doing. No, we need to treat problems with the cranial bones, with the stomatognatic system, with TMJ, with posture, with breathing, general health. So that's why it's like we need to use a multidisciplinary approach. And another thing about neuromuscular dentistry is objective diagnostic data. Bernard Jacobson, who is like father of the neuromuscular dentistry, many years ago, he said, if you can't measure, if you can measure, it's fact. If not, it's just your opinion. And we would like to treat our patients based on facts, not on the opinion. And also, if you can measure something, you can improve it. You can improve it. Otherwise, how you can improve it? You don't know. That's why we're using so many diagnostic modalities. We're using electromyography. We're using electrosonography. We're using computerized jaw tracking, polysomnography. We're using ultra low frequency TENS, T-scan, CT scan, MRI, 3D planning, and many, many other technologies. So basically, we based our diagnostic procedure on objective data. And what is more important, that it's not only measure anatomical structures, not only like user indexes and position of the joint in the cranium, etc. We measure physiology, and this is a huge difference between what the neuromuscular concept can offer compared to other technology. So this is what neuromuscular concept means. Now, a lot of things related to the position of the lower jaw. And if we're talking about lower jaw, we're talking about the 6 dimensions of the lower jaw position. 6 dimensions. And this is horizontal, vertical, sagittal. Also, we have a pitch, roll, and yaw, right? It's 6 dimensions. And if we're talking about all these 6 dimensions, okay, what the method we have to align our lower jaw to the right physiological position on a neuromuscular trajectory, on a physiological trajectory of the movement of the jaw in these 6 dimensions. How do you establish the physiological position of the lower jaw using the 6 dimensions of the occlusion? Basically, we can use an ultra-low frequency TENS, and if you would like, you can use also Newcomb. But the TENS is a key here. And it's so many TENS units on the market. It is you see, it's many. Like if you go online, you can find like hundreds of TENS unit, and TENS we use in many discipline, like in sport medicine and physiotherapy and pain medicine, and not only in dentistry. But in dentistry, we use ultra-low frequency TENS. At least we use in the neuromuscular concept. And this is very important. This is very important. Because, you see, we have a high frequency TENS. It's between like 80 and 100 hertz. And this is like eliminate or diminish the acute pain. We have a low frequency TENS, which is less than 10 hertz, to work with a chronic pain. And we use an ultra low frequency TENS, which is less than 1 hertz. And this TENS was FDA approved to use when we register the occlusion. No other device approved to do this. You can relax muscles with low frequency TENS, but to record the occlusion, we need to use an ultra low frequency TENS. And this is how it works. We place myotrodes in the area of the mandibular notch for the purpose of stimulation of trigeminal and facial nerve. Also, we put the myotrodes on an anterior surface of the cervical triangle for the purpose of stimulate the accessory nerve. Basic electrodes we place on the neck, right? And this is how we stimulate all muscles innervated by trigeminal, facial, and accessory nerve. And this is all chewing muscles and most of the neck muscles, all right? And the signal actually coming to these base electrodes, and then it's travel to the electrodes on mandibular notch and the anterior surface of the triangle, neck triangle. All right. But we did another study with my friend, Dr. Yurin, and he put electrodes in anterior in the ear, all right, and one inside the ear canal, and another is behind the ear, and this looks like this. And we did this study to show that stimulation of the trigeminal and facial nerve actually stimulate the contraction of the lateral pterygoid muscles. And you can see here, like he performed surgery, TMJ's surgery, and during the surgery, he took this video and picture what I'm going to show you. And you can see this is needle electrodes inserted in the lateral pterygoid muscles. And this is another TENS electrode put inside the ear canal. And another electrode, you can see this in these pictures behind the ear. But look how this how does it work. You can see that how this muscle contract, and then we did electromyography and you can see the contraction of the muscles. This is what the signals coming from this to this needle electrodes. So basically, this is another way of stimulation, because the facial nerve, which branches from facial nerve going through the ear, it's facial nerve has anastomosis. It's connected to the trigeminal nerve. It's like same network, let's put this way. All right. Now, during the TENS procedure, what we're getting? We're getting the mild relaxation of the muscles occurs by means of removing products of metabolism and first of all, lactic acid out of the muscles, because the muscles accumulate a lot of lactic acid during the spasm. This kind of stimulation allows not only for the muscle relaxation, but also helps with the reprogramming of the muscles, making it possible to find optimal position of the lower jaw. It increases the blood supply and oxygen supply, also ATP, calcium, and glucose. Turns muscles metabolism out of anaerobic process, which is lactic acid, into the aerobic Krebs cycle, which is 8 times more effective. And also it causes antidromic, atypical compared to the regular transmission of the nerve impulses. Antidromic hyperpolarization of motor neurons and proprioceptive feedback connection interruption in a impulse transmission. So this is what happened, and the result of this, we have a relaxation of the muscles, and the jaw moves forward in most cases and down to the physiological rest position on a physiological trajectory of the lower jaw. And Dr. Norm Thomas, in one of his studies, he suggested this diagram. And as a result of TENS stimulation, we have an interruption of the signal of the feedback from the muscles on the level of alpha and gamma motor neurons. And now, since these interruptions exist, TENS kind of take a control. Not the CNS. TENS takes control on contraction of the muscles, and this how we temporarily erase these pathological engrams what muscles could have. So, and this is what we relate to antidromic refraction of motor neurons. And if we're talking about TENS unit, alpha frequency TENS, we're doing two things, at least two things: muscle relaxation and inhibition of pathological engrams. Also, because of this, muscles move lower jaw on a physiological neuromuscular trajectory in the position of the physiological rest. On the other hand, if we're using NewCam, it brings your body to the pre-sleep state, characterized by deep muscle relaxation, not only muscle, like body relaxation. And we can use this position, physiological position, to register therapeutic optimal occlusion, to decompress the joint, to do physical therapy to TMJ when we have a TMD issues. We can do selective enameloplasty. We can do full removable prosthesis. We can treat sleep apnea. And when we're doing the selective enameloplasty or registered therapeutic optimal occlusion, we can also use a T-scan and DTR technology to finalize micro occlusion. And also, I'm going to show you how we can use this technology to determine the physiological bite. So we tense patient, and as a result of this tensing, like I said, the jaw moves to the right physiological position. And again, we can use up to hour, like 60 minutes, to do muscle relaxation and get rid of like pathological engrams. Also, we can use some indexes, like vertical indexes, Shimbachi and LVI indexes, and it will help us to put the jaw in the right position in a vertical plane. I'm not going to kind of give you details on this because it's definitely going to take me more time, and most of you probably know everything, and some of you who don't. So obviously this lecture not enough to give you details. But the one thing I have to tell you that TENS kind of doing the job. TENS putting the jaw in the right physiological trajectory and right rest position, and we can use this position to determine the neuromuscular occlusion. And as a result, we're getting this neuromuscular occlusion, and we're getting this type of record what you can use for your future treatment. All right. The one thing I want to show you, because very often I see doctors who kind of determine this using TENS, using some elements of neuromuscular concept, but in the end, they're getting wrong result. This is a diagram of the kinesiography. And you can see the habitual occlusion. You can see the habitual trajectory. And you can see the neuromuscular trajectory, right? And you see the physiological rest. This red dot, physiological rest position. And how we got there? After the TENS procedure, the jaw went to this position. This is a sagittal view. All right. And we know that we have to go up to like 1.5, 2 millimeters up along the neuromuscular trajectory to establish neuromuscular bite. This like black square, right? But it's also another line goes from the red dot to the habitual occlusion. And this I call reciprocal trajectory. What it is, we just simply told patient to close his or her mouth. And this is how they close. They turn on central nervous system, and this is a reciprocal response. This is how jaw goes to close the mouth. So, and you see, if we gonna go from the level of physiological rest up 1.5 millimeters, the same distance what we went along the physiological trajectory, we see the reciprocal target, reciprocal occlusion, gonna be vertically the same, but the jaw moved distally 2.1 millimeters. All right. And as you know, this distal movement of the lower jaw is very, very critical. It's right here instead of to be in the front. And this is how we're getting wrong occlusion. So, and most likely some people who is just using DTR or just using T-scan and establishing the occlusion this way, this is what we're getting very often. Distal position of the lower jaw with all this bad stuff, what can happen during this distal movement. It's like compression of TMD, it's narrowing of the airway, etc. And let me show you in a conclusion this case, because I know that I have to show you teeth, right? Otherwise, it's not gonna work for dentists. So this guy, Richard, presented with a chronic headaches. He lost his vertical dimensions of his bite. And if you take a look on his teeth, you can see that they grounded severe attrition. His teeth were largely worn out and eroded and decayed. And obviously, if we want to restore these teeth and get rid of TMD symptoms, we need to change the position of the lower jaw. And you can see what's happened with his dentition. This is most likely because of grinding. as a result of grinding, his Shimbachi index, which is a vertical index in the front, was 14.6 millimeters. And for him, it's supposed to be 16.7. The habitual trajectory and the habitual position of the lower jaw was shifted distally by 1.3 millimeters, which causes pronounced hypertonicity of the temporalis muscles. And this patient was diagnosed with sleep apnea because we did a sleep study on him, but he had a loud snoring. It didn't bother him. He just came because he realized that his front teeth become very short. And you can see his electromyography on the left with a hyperactivity of the temporalis 10.9. On the left side, and the right side is 2.7. And computerized movement of the lower jaw on the sagittal frontal space plane. And we did a test and we established his occlusion. We established his occlusion right here on where you see the black square. We use a standard protocol by using TENS, by using Newcomer and Key7. As you can see, we opened the bite by 4.6 millimeters and jaw moved forward 1.5 millimeters. And this is where we established the position of the lower jaw. We call this constructive myocentric, constructive bite. In this bite, we produce the neuromuscular orthotic. This is a bite. It was a removable orthotic. In his case, it was milled acetyl resin natural fit orthotic. Looks like this. And we treated our patients for like 3 months. And during this period of time, we did adjustments of orthotic with use of TENS and T-scan. And this is our result. With the creation of the neuromuscular occlusion and the restoration of the physiological trajectory of the lower jaw and the height of the bite, muscle tone, you can see, normalized. The proportion of the face were restored and snoring significantly decreased. And you can see that his jaw now on a neuromuscular trajectory and no TMD symptoms, headaches completely gone. It's one of the indicators. Perform treatment in the neuromuscular concept certainly restored the aesthetics of the smile and the proportions of the face, but most importantly, restored the physiology of the muscles and improve the breathing during the sleep. during the sleep. Suddenly, our patient began to look and feel younger, but most importantly, his well-being improved. And another thing I want to mention, that neuromuscular occlusion is the key to the success of the treatment, despite the disproportion between the natural crown, actually the natural crown, but left from the natural crown of the tools, and the artificial crown. You see, this is like huge, big discrepancy, and sometimes people think that it's not going to work. But since this is neuromuscular occlusion, since the muscles not going to be in hyperactivity, it can definitely work. It definitely works. All right. Today, multidisciplinary approach in neuromuscular dentistry allows not only save the patient teeth and to be healthy and beautiful for life, not only relieve the patient of headache, jaw pain, and other symptoms of TMD, but also prevent the occurrence of cardiovascular, endocrine, and other diseases related to the posture, and even prolong the patient's life for 10 or even 15 years. Thank you very much.